Thank you very much. Good afternoon. So I'm going to talk about biceps pulley lesions and biceps instability in the next 10 minutes. And to remind you, the overall arc over this session is how to help the shoulder surgeon. So 2 weeks ago, I asked my shoulder surgeon, because we have a very close collaboration, how can I help you with the biceps pulley lesions? And so the first answer he gave me is, show me the anatomy. So the surgeons are interested very much in the anatomy, and I'm going to start my talk by showing you also the anatomy. Then we move on to different types of pulley lesions and how we can diagnose this at MR arthrography and also at standard MRI. We move on to biceps instability, and then to CT, arthrograms and ultrasound, and finally I'm also going to talk about therapy. Let's start with the anatomy. Here you see an anatomical drawing of the biceps muscle, and as the name says, there's two heads, the long head which goes from the supraglenoid tubercle and the superior labrum, as you've already heard from Christian Glaser, and the second head, the short head, which originates from the coracoid process. Let's focus on the long head of the biceps tendon. You can see there's two portions of the biceps. There's a horizontal intra-articular portion and the vertical extra-articular portion. So we have a 90-degree angle that this tendon has to perform, and with this large change of direction, we need a pulley, like this pulley for pulling a rope. We need something at this location for pulling the tendon in a different direction. Some clinical aspects on the long head of the biceps tendon. So the lesions are most common at the supracromial part, and the long head of the biceps tendon is an important pain generator. My shoulder surgeon also calls the long head of the biceps tendon the appendix of the shoulder. Like in the abdomen, it's a small structure, the appendix, and it has limited function, but it can lead to a lot of pain. So this is also similar for the long head of the biceps tendon, and I will show you why. And finally, the clinical tests are often equivocal, so we as radiologists can step in and help the surgeon. Let's look at the anatomy here of the rotator interval, and for this it's most helpful if you have high resolution MR arthrograms. This is a oblique sagittal T1 weighted sequence, and we go here from medially to the other side laterally. The first two structures that I marked here are the supraspinatus tendon above and the anterior aspect of the rotator cuff, the subscapularis tendon. In the middle you can now appreciate in red the biceps tendon, so we start at the supraglenoid tubercle, and then as we move further laterally you can see the tendon is going more inferiorly. The next structure is the coracohumeral ligament, here marked in green. It starts at the base and the process of the coracoid, and it moves further laterally and changes shape and signal intensity. And finally, we have the superior glenohumeral ligament marked here in blue, and these two structures together make this sling that stabilizes the biceps tendon. What is the definition of the biceps pulley? The most common definition is these two ligaments. So it's a sling of fibers, fibrous bands between the coracohumeral ligament and the superior glenohumeral ligament. But there's a broader definition. So some people say you need to include the upper border of the subscapularis tendon as well, not only these two ligaments. And finally, some authors say some fibers from the anterior border of the supraspinatus tendon are also important for stabilizing the biceps tendon. What are the functions of the biceps pulley? So it's guiding and stabilizing of the biceps tendon during this deflection from the intra-articular horizontal part to the extra-articular vertical part. It prevents the medial subluxation of the biceps tendon. And finally, the pulley and the biceps together, they also stabilize the shoulder against the superior translation of the humeral head. This is especially important for patients with supraspinatus tears. What does the surgeon see during arthroscopy? So here we have a view from the posterior portal. We look down on the humeral head here below, and you can see the biceps tendon, how it's going down into the intertubercular sulcus. On the medial side, you can see the subscapularis tendon and its top border, and then marked in green here is the biceps pulley, consisting here again of the superior glenohumeral ligament and the coracohumeral ligament. And this is a reinforcement for stabilizing the long head of the biceps tendon. Let's look a bit more closely at MR images. So these are two sagittal T1 weighted MR arthrogram images. It's the same image. So ones are marked here the biceps tendon, and the other one is the original image. And we can see we are at the level of the coracoid process. So here we have the overlaying biceps pulley. In green it's the coracohumeral ligament, and in blue it's the superior glenohumeral ligament. And you can see here the coracohumeral ligament is at the top. It's broad, it's quite dark, and the second structure, the superior glenohumeral ligament, starts as a round structure. So here it's a focal increase of the joint capsule, and then as we go along to the lateral portion, this superior glenohumeral ligament gets flatter, and finally these two form this sling. So at the top you have the coracohumeral ligament, and at the bottom you have the superior glenohumeral ligament. Important also here to consider the attachment side of the superior glenohumeral ligament. It's exactly at the top border of the subscapularis tendon. How does a normal pulley look like? So as seen here, that's the impact pulleys. You see adjacent to the biceps tendon, you see these both ligaments, and there's a nice sling. Please note there's some fluid here between the pulley and the upper border of the subscapularis tendon, so a little bit of fluid there is normal if you can identify the structures. The other thing to consider is the position of the biceps tendon on these transverse images. It's exactly where it should be, in the middle of the intertubercular sulcus. Now let's go on to the pulley lesions. In this case, the biceps tendon is cutting into the subscapularis tendon. You can see like a knife cut into a piece of bread or meat, maybe. You can see that the biceps tendon is cutting into the upper and medial border of the subscapularis tendon. And this can also be appreciated in the sagittal sequence here. And if you see this, that's very easy. So we have medial subluxation of the long head of the biceps tendon. This means we have both a subscapularis lesion and also a biceps pulley tear. This is a very specific sign. Unfortunately, it has quite a low sensitivity. There's other signs we can see. This is another type of pulley lesion. Here we have discontinuity of the superior glenohumeral ligament, and you can see this gap in here. This is from a nice paper from Christoph Scheffler that was published 5 years ago. He and his colleagues, they compared different signs for biceps pulley lesions. And the best sign they found was this so-called displacement sign. It's illustrated here. If you have a direct contact between the long head of the biceps tendon and the subscapularis tendon insertion, this is called displacement if you compare it to the normal position. And if you see this at MRI, it has quite a good sensitivity with 75 to 86% and a high specificity of 90 to 96% for identifying biceps pulley lesions. There's classifications for biceps pulley lesions. I only mention one here in this talk. This is the Haber-Meyer classification, and this is taken from the upcoming book MRI of the shoulder from the ESSR sports committee that will be published in November. So the first type here is type 1. You can see a discontinuity of the superior glenohumeral ligament. In type 2 you also have a lesion at the supraspinatus and more eccentricity here of the tendon. In type 3 you have involvement of the subscapularis tendon of its top border, and in type 4 you have both a supraspinatus and subscapularis tendon tear together with the pulley lesion. Why is this important? Pulley lesions are often associated with other lesions, so lesions of the rotator cuff and slap tears. Your surgeon obviously is very much interested in the associated lesions, so if you report a pulley lesion to the surgeon, also report the other associated lesions that might be amenable to surgery. The biceps tendon can dislocate depending on which part of the pulley is torn. So it can be a deep or superficial dislocation, as we can see in two cases. Once we have a posterior dislocation of the biceps tendon, and here the tendon is dislocated anteriorly in this other case. These are a couple of more images. We can see on the top row, the biceps tendon is centered. On the lower row, we have an eccentric biceps tendon. So again, is this here biceps instability? In this case, it wasn't. These are actually asymptomatic volunteers that were scanned. And so beware of the shape variations and also of the somewhat slightly eccentric positions in some healthy individuals. So not all eccentric biceps tendons indicate biceps instability. Biceps pulley lesions can also be detected at non-contrast MR. This can be quite difficult, but like in this case, sometimes you have some fluid inside the joint or in the bursa, and then it's almost identical to MR arthrography. You can see in this case the biceps pulley is intact, but we have an articular-sided partial tear of the supraspinatus. If you're performing CT arthrograms, you can also assess the biceps pulley. On the left side here, you can see a normal biceps pulley, and on the right side, a pulley lesion with tearing of the superior glenohumeral ligament. And sonography can also be helpful in assessing the biceps pulley. So the first case is a partial tear of the subscapularis tendon. We see the biceps tendon is missing in this case. And also in the second case, the biceps tendon is missing. So if you have an empty sulcus, look for your biceps tendon and you can positively identify the biceps tendon dislocation. So let's finally move on to therapy. In our hospital, the surgeon tries to be as conservative as possible in these cases. They will order some physical therapy for the patient. If that doesn't help, if the patient still has symptoms, then they will do glenohumeral steroid injections. So they send them to us, to the radiologist, to perform these injections. If a surgery is necessary, there's different options. The first one is to cut the biceps tendon, so this is biceps tenotomy. The second one is if you screw the tendon into the intertubercular sulcus with an anchor, biceps tenodesis. Then you can do a pulley repair. You will hear a little bit more later about this, but there's different schools on that. So some surgeons like that a lot, and other surgeons think it doesn't make a lot of sense to do that. We'll discuss that a little bit later. And finally, don't forget, the surgeon also needs to address the other damaged structures, not only the biceps pulley. At Balgrist, we usually perform biceps tenotomy plus the surgery of the other damaged structures. And just a short note on the biceps tenotomy. What happens if you cut the biceps? As an athlete, are you losing your strength without your long head of the biceps tendon? And luckily, in these patients, the short head of the biceps tendon is able to compensate for that, and it has 95% left on the total strength. So for most of us, 95% would be fine, and also for a lot of athletes, that's enough. But if you're really looking for the last 5%, it might be reasonable to refixate the biceps tendon, even though we have to say some athletes have residual pain after these surgeries. And so if you have high strength, 100% of strength, but some residual pain left, you will also not reach your level, pre-injury level that you had as an athlete. The other thing to consider is if you cut the long head of the biceps tendon, you will have a retraction because the muscle belly contracts. So in the end, it might be a cosmetic problem that arises, not actually a problem of muscle strength. Let's briefly summarize. In the beginning, we looked at the anatomy, so we were able to show now to the surgeon what the anatomy looks like with the coracohumeral ligament and also with the superior glenohumeral ligament. Then we looked at different types of pulley lesions and how we can diagnose them with MR arthrography and other modalities as well. We looked at different patterns and types of biceps instability, and finally I was able to show you a couple of things on therapy. With this, I'm at the end of my talk, and I would like to invite you, if you're interested in sports imaging, to the meeting we're doing in Zurich next year on lower extremity. It's on April 20 and 21, 2018. Many thanks for your attention.